Okay, we're going to bring the Ad hoc Committee on Alcohol and Drug Abuse to order. I'd like to begin with just introductions around the room. Want to start with Amanda?
Amanda Moser, Clerk's Office.
Pete Peterson, Assembly.
Helby Gray Jackson.
Bill Evans, and if we can go around the room real quick. Zach?
Kate Toomey, Alaska Food System. Beth Wilson, Coconut Travel Council.
Asha Farmer, Coconut Travel Council.
Yeah.
Roxanne Boylan, Citizen.
And I'm Lieutenant Jared Toohey. I'm taking over, well, he's Captain Gary Gillen's spot in the CAP team, so I'll be here for a lot of these meetings and get to know all of you guys.
Warren Jones from First Covenant Church, APAC.
Janet Jones, First Covenant Church, APEC.
Barbara Garner, University Area Community Council.
Stuart Baden, Anchorage Community Land Trust.
Carmen Springer, Anchorage Coalition to End Homelessness.
Melinda Freeman, the Director of the Department of Health and Human Services for the UD.
Jeff Jesse, Mental Health Trust.
John Hollenweider, Park Community Member.
James Dennis, Battalion Chief, Anchorage Fire Department. Sorry.
Kate Pearson, Community Member.
And Christopher Constant with Fairview Community Council and et cetera.
I'm Dr. Mike Levy. I'm Anchorage Fire Department Medical Director, ASP Medical Sponsor, Emergency Physician.
Steve Ashman, Department of Health and Human Services.
Great. I'll give you guys a B for that. It was a little confusing there for a while, but you pulled it together in the end. We have a very full agenda, so I want to get right with it. Our first presenter today is Dr. Michael Levy, and we'll leave the floor to you.
So I can plug in if you want me to, or I can just speak. Did you guys get a copy of some notes that I made?
We're going to
Is it-
we're going to get those to everybody.
Okay. Maybe if I could, I'll just see if I can just jack here real quick. I hope that I'm just kind of a resource because of the things that I do. I'll just throw a few things up there, and I want to know the time constraint so I don't just ramble on. I can either have the cane put to my neck and pulled off stage, or you can just tell me how it's going and tell me to shush up. So I appreciate the opportunity to come in and say hi to everybody. Again, I see myself more as just a sort of a resource of a person that's been in this setting. And again, the setting that I'm in is that I'm an emergency physician. I've been an emergency physician since 1987. I have worked in various settings where I'm just immersed in substance abuse, alcohol, etc. After leaving my training, I took off and went to Chinle, Arizona with the Indian Health Service, and so I worked in the middle of the Navajo Reservation, where there's a lot of binge drinking, not so much chronic because it's a dry reservation, a little harder to be chronic there. People usually move on to Gallup and that area to become more immersed in the alcohol abuse. And then I've been an emergency physician here in Anchorage since 1989, where I came in at the Native Hospital, the old Native Hospital on the Bluff. And so again, I think I've kind of been there and seen quite a lot in this regard. Again, I'm here with the fire chief and other folks, but I'm not here as a representative of the fire department per se, and so I'm not putting across things that has been vetted through the fire department in terms of policy or the like. And I'd like to be clear on that. Similarly with my hospital, Alaska Regional Hospital. Those are my bona fides, a few of them on this. These data are going to come to you, and you've probably already seen them as well, so I don't know that it's really important to dwell on it because you folks have probably already spent a lot of time looking at these. We all know that alcohol is a big problem, and the recidivists and the high users maybe are the most important point that needs to be addressed would be, I think, my point on these slides in terms of the overall number of people that are using the services, but moreover, the people that are duplicated services and the very, very high users, I think, are something that require some focus. These, again, are slides that will be available to you, so not to dwell on them too much, but it again reiterates the fact that there is a core group of people amongst all these people who are very high users of the. We see an escalation in the alcohol, blood alcohol in people as well, the breath alcohol people. It might be worth looking just at the institution in town here that sees the most of this. I just got this slide from one of the physicians there. And so at Native Hospital, just looking at, I think it was an 8-month period, they see basically the same pattern, that it's the recidivists and people that are very high users that end up consuming a lot of resources. And this again goes back to the fact that this is Native Hospital, which sees more of the alcohol abuse problem perhaps than the other hospitals, but believe me, I'm immersed in it day in, day out with alcohol use as a reason for coming in. So the different factors that occur in the EMS world with regard to the alcohol abuse problem, it really starts at the very front end. Our dispatchers take the calls and have to handle calls, sort them as to whether they're alcohol related or not. About year 2013, the Anchorage Fire Department took over dispatch for CSP, for ASP now, and would parse out these calls to ASP preferentially when possible, to AFD, law enforcement, to the transport services, Anchorage Fire Department. But Anchorage Fire Department is a huge responder to these calls, and we'll hear more about that later as well. In just the first quarter, essentially this year, we loaded 9,000 ASP incidents into the dispatch center. So you can see what kind of impact that has on the fire department in terms of all the other duties that we have to that we've assumed and which we do. Title 47, to touch on it real quickly, is laid out here. Again, it's in the writing. I'm sure you folks have gone through this over and over again with regard to Title 47. Title 47, from the role of an emergency physician, could be a very helpful tool, that it exists and gives us an opportunity to take people who put themselves at risk and to, through this state law, allows us to take away some of the person's civil rights and their own benefit, essentially. However, the bad news about it is that there's no good mechanism that exists in this community to actually use that law on an ongoing basis. It has too much overhead for the kind of way we practice medicine in this town. So what I mean by that is I'm fee-for-service private practice, emergency physician in a contract situation with my hospital. That's the way it is in most places. At Native Hospital, it's not that they are paid employees, but again, the structure is really not in place for a person to, one, do a screening exam on an individual, go through signing the affidavits and the like, and then the real big overhead comes from having to do it again, because there's a time frame in which you need to recertify that the person still should be in that setting. And there's really no way for us to take that responsibility in emergency medicine, and there seems to be no one else in the community besides emergency physicians who are on the front lines that are even asked to do this, to my knowledge. If people know more about that than I do, and there's something else going on, that's a great thing. I would really love to see this become a better tool than it is right now. People in this room have memories, certainly, at a time when one physician was working very hard to take pregnant chronic inebriates and applying Title 47 to try to come to a positive benefit in that regard. But that required a lot of ongoing maintenance, and once that person was gone, I believe that stopped happening. So this is just more Title 47 stuff here. With regard to the EMS costs that we see, people in this room, I'm sure, are savvy enough to know that the ambulances are paid for, the personnel are paid for, so the incremental cost of us running on a person is essentially zero except for the fuel we use, right? There's no marginal cost per se except just the transportation cost. But I'll guarantee you, and I'll take this one to the mat, that it has huge costs on the fire department. It has huge costs because it causes attrition in our ranks. It runs our people down. They run all night long, and they do a very good job of acting compassionately in situations that are very challenging, having to do with the alcohol and homeless population in the community. As a consequence, down here in what we call the Station 1 area, we lose people from our frontline medic ranks, and I think it largely is due to just this problem. It is just grinding. It's relentless. You're up all night long. You're seeing a lot of the same stuff. And that eventually causes people to move out of the paramedic ranks, out of the frontline EMS ranks with our paramedics and firefighter EMTs. And they move into less grueling stations and less grueling activities. And there's certain benefits to that, and benefits to the fire department, but overall, we have training costs and we lose those people to this. We have, I think we all suffer a little bit from compassion fatigue, day in, day out, seeing folks who we've seen before, have done it again, and they've done it again. And it's pretty hard to know that you're not changing anything. So I think anything we can do as a community to move forward and show some positive outcomes in some of these people would be huge. It'd be huge for our department, our fire department, it'd be huge for the emergency departments. I think it's probably been pointed out here too, we're getting younger populations at ASP, we're getting, we have a number of deaths. Just anecdotally, one of the women that works at ASP last year told me, because she keeps count of these people because she knows them, that she saw an attrition of over 60 deaths from the population that was the recurrent population to ASP for a variety of reasons. Not people just dying in the facility itself, certainly, but they were dying just of natural causes of being found. One of those homeless people found out in the woods in a camp or something like that. But I was very surprised by that number. It's an unvetted number, but I would not be surprised that that's a valid number. We're seeing more kind of mixed problems. Certainly there's always the mixed mental health and alcohol problem. But in addition to that, the spice, the bath salts, meth have led to an increasingly violent population. That's led to more problems down at the ASP as well in terms of getting law enforcement involved in it and risk to the people down there. Let me just jump over to the emergency department, which I'll be jumping to again at about 3 o'clock this afternoon. In the emergency department, we see lots and lots of alcohol abuse. This is not a facts and figure thing. This is just a qualitative overview. But day in, day out, we are seeing all kinds of people whose reason for being in the emergency department is either primarily or secondarily related to alcohol abuse. What these people do, if we bring somebody in from EMS to the emergency department who is obstreperous and acting out, intoxicated, and can't be released to the street because of their mental status changes, it's honestly as labor-intensive as the biggest medical intervention. It's as big and labor-intensive as a major trauma. To have that person contained, restrained, to have the personnel there to take care of them is a huge draw down on our resources. So there are costs associated with that. When you see the diversion problems we have in the community with hospitals not being able to take more patients, some of it is due to the fact that we cannot move patients up to the floor, but a lot of it's due to the fact that our emergency departments are at capacity, and when we have a person sobering in a bed for 8 hours in the emergency department, it's another huge opportunity cost for the community in terms of getting it to an emergency department. When somebody comes to me, I will tell you, just since we're all friends here, that this idea that we practice defensive medicine is 100% true. There's no debate about it. It's 100% true. We just do. And so folks that we see who've come in with alcohol-related problems, they are a group of people that often will have, for example, subdural hematomas. They have altered mental status, and they'll have been fallen down, bruises on the head. They will get CAT scans. There's any number of individuals who've had 5, 10 CAT scans a year, and I'm probably underestimating that, because you look, there's nothing, you look, there's nothing, you look, there's something, you look, there's nothing, you look, there's something. So we're spending, CAT scan at cost is probably a few $1,000s, readings, all those sorts of things, radiation exposure. So there's a lot of problems with that regard too. What also happens in the emergency department and affects our friends in law enforcement is that when they want to, when somebody has alcohol involved, for the most part, if the person has to be taken to corrections, they cannot be remanded to corrections unless they've been so-called cleared, which is basically liability shifting is how I see it from the community to the emergency physician. So a person with some level of inebriation is brought in, and we have to, quote, clear them for the officers. And we can be tough on the officers and say, we're not going to clear them, sir. But what happens is that the Anchorage Police Department becomes the badminton birdie knocked over the fence back and forth because they won't take them at corrections until the person's cleared. And so it becomes kind of a glorified taxi service. And so we just mostly do that just to move things ahead. Are there any solutions to this? Well, that's what you guys are looking at, and hopefully this is what you folks will be able to solve. I'm not an expert in addiction medicine, and it's not my forefront of professional interest, but it's something that I'm immersed in, day out. It seems to me that everything that will happen that's of benefit will be a community effort, because I can't see that there's one simple thing that's going to make this all better. But I think the fact that I heard all the different people who have a vested interest in this are sitting at this table can make a big difference in it. There's very little access to treatment that I can see from where I sit as an emergency physician. It's backed up. There's no, they require medical oversight, but there's no fixed medical oversight. So for somebody like me, it's another job is assigned, and quite honestly, it's something I'm doing only for medical legal risk, and I probably never get paid for it. So it's not a great inducement for an emergency physician to be involved in it, except as we have to by the fact that we are in the emergency department. If we could use Title 47 more effectively to try to help people through this problem by getting them into treatment, I've certainly been told by people that are expert in this, such as Melinda, that if you can get people dried out a little bit and get a chance to talk to them, you get that opportunity to sort of make them make their own choices. Supportive housing that works within the framework of how these people live, I think, is a demonstrated benefit, and it's something we need to think about. Issues of preventing homelessness and et cetera are important. I think a mental exercise that might be worth going through is to look at what happens if the safety net's not there. I think if you just frame this in terms of no emergency department, no fire department, no ASP, how would this work? How would this idea of homelessness and alcoholism work? We've become facilitators of this. We're not really helping anything. There's no reason that an inebriated person in and of himself is my medical emergency. Certainly it could become that. But it's become, because there are places where everything can kind of drift down to, we've become the holders of this hot potato. But in honesty, I think what you need to do is cut those safety cords and think how that's going to work in the absence of trying to framing this in a medical model. So I probably rattled on enough here. I wanted to throw that out. This is just coming from my perspective as the guy that's the EMS guy and the emergency guy.
Thank you, Dr. Levy. We certainly appreciate your time and your comments. Are there any questions, Mr. Peterson?
Thank you, Mr. Chairman. You mentioned Gallup, New Mexico, earlier and I actually was listening to the radio and heard something on the news that they had 17 street inebriates that froze to death in Gallup over this last winter.
Wow.
And so obviously they have got a similar problem to what we have here in Anchorage. And do you know that what are they doing? Or what they're doing must not be working. But
I think that maybe Melinda knows more about this than I do, or someone might. But I know that they've had a sobering center down in Gallup area that's been a model for other places in the country. In fact, I know back when Downtown Partnership had the contract for ASP, then CSP, that they sent a delegation down there to try to learn from it.
Yes, they have what's called a social detox model. So in addition to medically monitored detox, they have what we think of as an outpatient detox program as well, and that can be very effective. And so we'll be hearing from treatment providers today that can clarify that, Inland Tribal Council and other treatment providers to show you the range of treatment options.
okay, great, thank you.
Great. I do want to note for the record that Mr. Trainee also arrived about 5 minutes into Dr. Levy's presentation and was with us here. Dr. Levy, do you have any specific ideas about how Title 47 can be made to be more usable? I'm not putting you on a spot, but if you have any, I'd be glad to hear it.
Well, from my perspective, you have to have, it seems to come back to physician, or at least a provider, at some point in time has to do the initial, has to sign off on them initially, but then periodically has to re-verify that this person can remain in Title 47. And that, to me, has been a big fallout point. It's not something that myself or other colleagues feel comfortable being involved in. So I think if you had a person who had that responsibility, or a group of people that had that responsibility, and again, that probably comes down to payment. People who are in that setting who get paid to do that, then I think that would be a big step in making that more viable.
Thank you. Don't see any other questions. Appreciate your time again, and thank you for sharing all that information with us.
Appreciate it. I'm running off to another meeting, but thanks for having me.
Thank you. Okay, moving on. Our next presenter is Kate Sumi, is it, from the Mental Health Court?
Scoot down so I'm trying to stand up for you. Sure.
And also, there's pizza there for everybody. Just help yourself as we go along.
with the mental health court, with the Alaska court system, and as this is coming up, it'll help me follow along. The mental health court is a diversion program. It's a problem-solving court. People may have heard of our wellness court program. We have veterans courts, child and need aid courts. The mental health court is a program that works with people who have different types of mental health disorders, or we divert them from custody, or if they've gotten out of the ticket in the community, and we try and get them into treatment. So, trying to go off to my notes because I've always been trained to be prepared if the PowerPoints don't work. So I was asked today to address how the high numbers of individuals with what we look at as co-occurring mental health and substance use disorders. So we find the people that come through our mental health court program, and this program has been in operation, I believe, for 18 years now in the state of Alaska. It was one of the first mental health courts in the nation. It's an offshoot of the drug court model, problem-solving model. So we see a high number of people who have co-occurring substance abuse and mental health disorders. And we see these people frequently cycle through Department of Corrections. And a number of the people that come through are homeless. And not necessarily homeless, they may become homeless because they've been in housing placement and they have destroyed property at the housing placement, or they have assaulted their caregiver or another person that they live with. So they may have been housed and then homeless. So that housing is definitely an issue that is ongoing. So some of the priorities when somebody comes into our program is getting them into housing, and then of course for about 70% of the people that come through, getting them connected to substance abuse assessment and services. So what we find in Department of Corrections is we have in the state of Alaska, we have a very high percentage of what we call Alaska Mental Health Trust beneficiaries. So I know Jeff Dusty is here from the trust, and this is a diverse audience, but when we're talking about trust beneficiaries, that's a pretty wide group of individuals with disabilities, but we're talking about people who have mental health disorders such as schizophrenia, schizoaffective disorder, bipolar disorder, other general mental health disorders, major depression, anxiety, trauma, individuals with traumatic brain injury. I'll slide on that so I'll get there. Developmental disabilities are Alzheimer's and other dementias. And then the other category that falls in there is our chronic alcoholics. So it's a very wide group of people, and we talk about a therapeutic court program that serves Alaska's mental health trust beneficiaries. This is one of the we serve all of these people to a limit. There really has to be able to be the services to connect the person to in the community. And then a person has to be legally competent. So if somebody has Alzheimer's or other dementia, we usually try and get those cases dismissed, and there's a competency process. If people have chronic alcoholism and they're not willing to stop drinking, it kind of is beyond the scope of what we can do in the mental health court, although I have some examples of how we've worked with partner agencies with people who are working on harm reduction or want to move towards sobriety. So back up here real quick. I just want to point out a couple of studies that were done in Alaska's Department of Corrections to kind of give a perspective on the high number, the really, really high number of people that are going through Department of Corrections who are our trust beneficiaries. So in 1997, there was a study done. We found it was 37% of people. Now, of course, that group that I just mentioned, at that time, it didn't really include all of those people. So fast forward to 2008, we went up to 42%, and that's really where we included traumatic brain injury and a couple of other categories, but we saw a jump. Now, fast forward to 2012, we say 65% of people in Alaska Department of Corrections are Alaska Mental Health Trust beneficiaries. Like, holy smokes. So that increase from the 42 to 65% over a 4-year period, really what they included in that particular study was people who had substance abuse disorders. It's a great study that's out there. I mean, it's thick, so read the executive summary, but just perspective that we have a very high number of people in constantly cycling through our Department of Corrections, who are beneficiaries and who have a co-occurring substance abuse disorder, and a number who are homeless. So I talked on that. So some of the things that we find is that our trust beneficiaries, they recidivate at a higher rate than just non-beneficiaries. So that means they're getting rearrested, reincarcerated, reconvicted at higher rates. So they cost more money. And there's some cost figures there. And I think that you can send this to the group if you guys want it. Then some other highlights is we found that we have a disproportionate number of Alaska Natives. We have higher Alaska Natives and women that are trust beneficiaries. Also looking at the types of crimes that people are reconvicted for or rearrested for is that it's more serious crimes. Part of that is that people just keep coming through, and it's like they're escalating their level of criminal involvement. So those are some considerations. I don't think I have a slide on trauma here, but trauma is something that we also really see with a number of people that come through the criminal justice system, that very high rates of trauma, physical trauma, sexual trauma. So those are all some factors that factor in, and then kind of the underlying understanding of why are people doing a lot of these negative things to themselves is that they kind of have a bad life experience. We'll talk a little bit more about that. I'm not going to get too much into this, although I wanted to point out that with this 2012 study, 39% of people in Department of Corrections had an alcohol disorder, 41% a drug disorder. So what are some of the things that fuels the high number of our trust beneficiaries in the criminal justice system? Well, deinstitutionalization, I think folks in this room are old enough to have heard that term. But really, we looked at a decrease in psychiatric beds with from the 1950s to present, and that really still is the model. And our current model, if we are able to get somebody into Alaska Psychiatric Institute, is an acute care model. So really, they're keeping people for a very short period of time. So if somebody is acting out, whether that be a psychiatric problem, maybe some of these new designer drugs, and we actually get someone to the hospital, we see people, they're discharged a lot sooner than we would have seen 2 or 3 years ago. So very short stays. So part of what we see with people who have frequent contact with the institutions, they have institutionalized lives. They encounter the hospital. These are people who go to community mental health centers, assisted living facilities, alcohol and drug treatment centers, social welfare agencies. They don't have a lot of what we'd say is natural supports in the community. It's like a lot of professionals who are dealing with a lot of professionals who are dealing with some of the bad behaviors that people exhibit in the community. So another thing that we learned is, so we said that a mental health court's been around for like 18 years. At first we were like, get them beds, get them housing, they'll be fine. No. Really, what we found is that people also have criminal thinking. So the latest research is about criminogenic risk factors that lead to recidivism. So that's like a new term. But what we look at with criminogenic risk factors is this is antisocial behavior, antisocial friends. It's why somebody would, I'm sitting here, they would steal my iPad, my book. Why are people even doing that? They're thinking that people they hang around with, problems with family, problems with relationship, problems with school, they can't keep a job. They have problems, they have nothing positive to do in the community, no pro-social activities. And then the huge one, of course, substance abuse. So we used to think, let's get people meds in a place to stay and they'll be just fine. But you know what, we see those people come through the criminal justice system. So we're learning, hey, we gotta address many of these things. And substance abuse, again, 70% of the people who come through have these co-occurring substance abuse disorders. So that's really one of the key things. But it can't just be the substance abuse, because if you get sober and you're still criminal thinking, maybe you're just a bit of a better criminal. Or even if you get medicated, let's say you're borderline psychotic or you've been on some of these new designer drugs, and then you clean up, maybe you're a better criminal thinker. So we have to address some of these things to really help reduce recidivism, and substance abuse is one of the key things. So we find that our trust beneficiaries typically are at higher risk of experiencing these risk factors, criminogenic risk factors, because they haven't always been dealt the best cards in life. So these are people that we see revolve through our jails, through the PsychED, through our sleep off centers, through detox, the homeless shelters, the people you're calling 911 because they're acting strange in the community. These are some of the people who might be passed out on the sidewalk, but a lot of bizarre behaviors that we see, and criminal behaviors too. These are people who are undereducated, underemployed, extreme poverty. They may or may not be on Social Security benefits, but oftentimes if they've been in Department of Corrections, their benefits have been discontinued, and there's a whole other cycle of being able to restart those benefits that's very difficult. Number of people are homeless because of the reasons that I mentioned. It's maybe they had family supports, but because they stalked their aunt, their uncle, or if they're in some sort of housing placement, that their behaviors are just too extreme, so they've been kicked out. So this says 61%, but our data is really showing 70%. Consistently, 70% of the participants that go through our court program have co-occurring substance abuse disorder. Oh, here's a slide on victimization. Also, high risk of suicidality, and then there are other complicated medical conditions. So Dr. Levy had talked about deaths that they're seeing in people, not just related to alcohol, but all these other complicating factors that go on. So people who come into the criminal justice system who have mental illness, oftentimes have some sort of substance abuse disorder and horrible physical health problems that make their lives a little bit more challenging. And then lost family supports if they ever had them. So they're living in the streets, and when something happens in the streets, and I do this myself, if something happens in the street, I see somebody fighting, passed out, you call 911 to respond. And so that's where we see a lot of people end up in the criminal justice system, is because their behaviors are calling to the attention of the courts, of really law enforcement first, and then the courts. Civil commitment is something for people that can be considered, but as I said, that we really have moved to an acute care model, and arresting someone is probable cause is a lower standard. So let's say somebody has committed a crime, and the option could be for law enforcement to divert to PsychED, but maybe there's some injuries. So jail is open 24/7, and there's if you have probable cause, you can drop somebody off, and they really have committed a crime. And PsychED, sometimes what we see is people cycle back out onto the streets very quickly. Now a plug for crisis intervention trained officers through APD. Definitely, there's a lot of diversion that goes on, street level diversion that happens before anybody would ever get a criminal charge. But the reality is we're still seeing a lot of people come through Department of Corrections. So, talked about that. We see a whole range of charges that come through that are eligible for our mental health court program. It's really a misdemeanor mental health court program. We do take some felony cases. There is a felony diversion program for people who have felony crimes, but usually they've served a jail sentence or prison sentence first, and they're at the end. But a lot of the crimes that we see people is push, shove, assaults, because they're caregiver, a lot of minor assaults, lots and lots of trespasses. And when we see a lot of trespasses, that's when we really see people who have serious alcohol problems. They are not allowed anywhere, and then they come in the system. Sometimes we'll try and get them connected to some housing in the community, but they're still continuing to use alcohol. So they are really proving to be some of our very challenging populations. I'm not sure how much time I have left.
If you could wrap up in 5 minutes, that'd be great.
That sounds great. Okay, so just going to talk a little bit. So mental health courts, this is a diversion opportunity where we serve up to 75 people right now, and we can get people connected to treatment in the community. So we have case coordinators or social workers who work with the individual and the treatment providers We get people, meds, money, housing, and then we work on what I said, the criminogenic risk factors. And then this is monitored by the court. So Judge Rhodes and Judge Washington are our mental health court judges. We bring people before the court for regular status hearings so they can basically get incentivized or sanctioned. Sometimes we'll put people in custody. But the thing I wanted to focus on here, and really, of course, we're trying to reduce the number of trust beneficiaries in our criminal justice system. Some of the successes that we've had, of course, depends entirely on community partnerships. So if there's not treatment in the community, and this is mental health treatment, substance abuse treatment, it's really difficult to support individuals to be successful in the community. So a slide here that talks about all of our partners, which is pretty much all of the agencies in the community that works with people who are trust beneficiaries. We've got gaps, and I think you guys have all heard of gaps. Our number one gap is housing, of course, but we've also had some successes. So just to touch on a few of the successes, our primary referral source for our participants to address substance abuse treatment is South Central Foundation's Four Directions program. So I think 2 or 3 years ago, they got a grant to prioritize our population as well as a few other populations. What has been really key about that is getting people in for assessments, and then they've actually moved to a model more recently where it's more treatment on demand. So a person shows up for an assessment, they start pre-treatment, and then they get into, and this is outpatient treatment specifically, so they can start those services right away. It's been very valuable. And of course it takes longer if somebody needs a residential level of treatment, but they take care of the assessment at the front end, and then they work collaboratively to get people into our limited residential treatment beds either here in Anchorage or around the state. So that was the last one, but that's like our main one. We've been very, very successful. Another thing that we have really been looking a lot more at is adjunctive medication. So medications such as Vivitrol and Naltrexone. And this has really been very key with our clients who cannot stay in community without being picked up every week with new alcohol-related charges, and who are coming in with some of these high breath alcohol content. So we've been trying to do, as we figure this out, somebody comes into custody, trying to do as part of their transition back to the community is getting them seen by a provider to explore the adjunctive medications to help reduce the cravings for alcohol and other drugs, but specifically we're looking at alcohol. So we've seen a lot of success there, and more providers who are willing to prescribe these medications. And then as a person who's on the adjunctive medications, they can do the outpatient treatment, which is of course less expensive than residential treatment. We have not very many beds. I've got Clithro, a specialized treatment unit. It's not there anymore, but when it was there, we really had some success with people who were our chronic alcoholics and being able to do bed-to-bed, so VOC to Clithro treatment, and it was long-term treatment, like 6 months of treatment, and people were very successful. The aftercare plan, sometimes things fell apart, but we really saw some success with that program. And then the last one here, Carlick Manor. So we have been able to work with a few cases where the judges and the prosecutor have been willing to monitor people who are going through Carlick Manor, who pick up criminal charges. These may be people who are in a harm reduction model or moving completely towards sobriety, but we've been able to work with them to maintain their housing at Carlick Manor and have a period of crime, of reduction in jail stays and arrests during the time period. So we've done that with a handful of clients over the last couple of years, and it really just has to be the willingness of the prosecutor. But part of what we're looking at is keeping people in housing. So with that said, I just wanted to kind of do an overview of our program, how people get there, why we see such a large number of people in Department of Corrections, and then some of our successes that we're having with different types of treatment.
Simi, Mr. Peterson, then Mr. Trainee has a question for you.
Well, thank you, Mr. Chairman. I've heard good things about Clitheroe over the years, and it's now closed. Is it a funding problem, or what happened?
You know, I know that we have some people on the wait list to get into residential, so I know that, so the specialized treatment unit is closed down, but the residential program, I think that, I'm not with the agency, but we've seen it go through ebb and flows with different leadership, and, so, yeah, right now we don't have anybody in right now, and we're looking at a few people, I think, who are on the wait list.
Okay, thanks.
Mr. Trini?
Kate, how long has Clifford been closed?
Oh, no, the specialized treatment unit,
And the
which
specialized
was,
treatment unit, how
oh,
long?
that's, I think, a couple of years. Yeah, so that the funding hasn't been there for a bit. But I did want to highlight it because the specific group of people that that we sent there is that they weren't able to get them, I believe, in there on Title 47. But what we had was FUCO jail days. So people would have jail days because they would, so when somebody goes through the criminal justice system, they get a sentence, they say, okay, I'm going to do my sentence, and then I'll stay out of trouble. So they have what's called suspended jail time, then they get in trouble again. So people might have like 450 jail days. And usually with misdemeanor offenses, we're talking less than a year and usually about 30 days to 60. But if somebody keeps messing up, so, and these were people who had serious problems with alcohol and they kept getting involved in the criminal justice system. And we had people who had up to 700 or 800 jail days that was kind of hanging over their head. And so we used that as a way to, because we wouldn't usually be able to say, okay, you have to go to residential treatment because that's like jail days for treatment. But if somebody had a ton of jail time, then we could say, okay, you get jail for day-for-day credit for being in treatment. Now it comes back to, at that time, that was some very specialized stuff, a lot of coordination that was going. People had to be detoxed before they went into the treatment because they didn't have treatment. And of course we could detox in Department of Corrections, but that's just doesn't exist right now. But I did want to point it out. It was successful for a handful of people, and and so we had that criminal justice piece that was like, oh, you can go to jail for a year, or we can get you into treatment for 6 months.
Thank you, ma'am. Thank you, Mr. Chairman.
Thank you. How does detox currently operate within corrections? We have a speaker from corrections later. If you
No, I think that I would maybe let John Stoltman address that.
Okay, we can get to it.
Yeah, yeah.
That makes sense.
Okay.
I don't see any other questions. Thank you so much for being here and presenting that. And like most of our presenters, we reserve the right to reach out to you as we continue our work on this
Sure.
as a resource.
And the other thing is, I just want to make sure you guys know you're invited to come. I'll leave some brochures I'll leave brochures with you. You can pass them out, my business cards. Please come and observe a hearing, but call me ahead of time to make sure we're in, and you can get some ideas, and especially if you let me know ahead of time, the judges will be available to answer questions.
Great. Appreciate it. Thank you. And we will get the copy of your presentation, and Amanda will
Okay, thanks.
distribute. Okay, moving on. Our next presenter is Becky Ling from Cook Inlet Tribal Councils. Becky, it's all yours.
Hi, so my name is actually Sasha Cernan with Cook Inlet Tribal Council, filling in for Becky.
I'm back. I'm Cook Inlet Tribal Council, filling in for Becky.
My name's Becky.
Surprise!
No, my name's William Carter, Kate Becky.
So we're going to talk a little bit about the services that we provide to the community and to a lot of the participants that we've been talking about in the last couple presentations. I just want to say thank you for this time and for the presenters that you presented. So we have Cook Inlet Tribal Council Recovery Services, and what that encompasses is a brief outpatient, an outpatient, intensive outpatient, and day treatment that is located at the Cook Inlet Tribal Council building over on San Geronimo on the second floor. And then we also have Ernie Turner Center. Ernie Turner Center is our residential facility, and we accommodate a level 3.1 to a level 3.5. We also have a detox and a social detox at Ernie Turner. For our recovery services program, we do serve the Native population. So you are required to have a CIV card or be married to a Native or have children. We also offer assessments there. And if we can't accommodate to what people want, then we refer out to many different people in the community. We're huge on resources and we're huge on making sure that our participants get what they need if we can't serve them. Within our facility, we have teams for each participant. So we have a mental health clinician and we have a case manager. And so the way that we see it is that alcohol and drugs is a symptom of what's really going on. Right? So we have the mental health clinician that helps with what's going on the inside, with the behaviors, with the feelings, with how they act on those feelings, and the reasons behind the drug and alcohol use. And then we have the case managers who come in and they help with the outside issues. So they help with the housing, with the transportation, employment, finances, things like that. We offer many groups also within our facility. For our outpatient program, we have outpatient groups that we provide, family groups, we have intensive outpatient groups, an intense relapse prevention group, and we have gender groups, so a women's group and a men's group. We also offer parenting group. We do work closely with OCS and a lot of families. Within Recovery Journey, which is Ernie Turner Center, we have a trauma group. We have several therapy groups that we provide that our mental health clinicians teach, and then we have education groups that our case managers teach on life skills, alcohol and drug education, things like that. So we have a lot of our people, our facilitators take our family members out in the community to do like grocery shopping, and they learn a budget, right? So that when they graduate from Ernie Turner Center, that they have those skills set in place. We also have a detox facility, right? We have a medical detox facility. We have a bunch of excellent nurses there. We have a PA there who helps out. And within that, we have our fine Will, who's going to have an opportunity to talk to you guys as well. And what Will does is he case manages straight from detox, right? So there is a lot of times a wait list with a lot of residential facilities, and the wait list is not pretty when you think about it, right? Because it can be long. And so what Will helps do is he helps case manage our participants from medical detox into a place that can take an assessment, provide them an assessment right away, or to housing if they don't have housing, whether it be temporary or permanent housing, to several support groups that are within the community, right? And then if they are willing, then we also have a social detox program. So they go straight from the medical detox into social detox, where we provide assessments and we provide case management. And again, once the assessment is done, and we do this all within a 2-week period, so it's very intense. So once the assessment is done, then Will case manages them out into either our outpatient program, our residential program, we have room, or a residential program that fits their needs. So we case manage them all over Alaska. We have partners with many different residential facilities within the Alaska community. And then he also helps with any court hearings that they may have, again with housing, to make sure that if they are going to an outpatient program, that they have safe housing. One thing that we really try to do with the team that we provide to each participant, in social detox, if a person does need a clinician, we do have one on hand. We'll grab one from one of the teams to come and talk to the participant if needed. But we make sure that when our case managers grab our participants, that they start the housing and the employment and transportation right away, because that can also take a long time. I don't know if you guys have seen the wait list for housing, it's also pretty long as well. So we start that right from the jump, because we want the best success for all of our participants.
So we recently started a new model that we
are just now starting to collect our data on, and that is really trauma-informed care.
Yes.
And so what we found is that when we have someone coming into detox and they want to move to social, they'll meet with Will, they can meet with the therapist, they do the assessment, say they're going to go into our residential. They'll get assigned a clinician, a case manager, and they work with them through the whole process. So when someone gets out of residential, they'll probably go to outpatient or intensive outpatient. They'll keep that same clinician, that same case manager through that whole process all the way to continuing care. Before, it would someone go to residential, then they go to outpatient, they get a whole new therapist, and then they have to build a whole other relationship. So we've seen a lot more graduates from our outpatient program since we went to this model.
We also have, within Ernie Turner Center, which is the residential facility, we have telepsychs. So on top of the clinicians, we have telepsychs who meet with our participants bi-weekly for anywhere from an hour to 3 hours, depending on the need. And so these telepsychs help them with a lot of things they have going on, and our case managers link them up with a primary physician here in Anchorage. And what will happen is once they graduate, they have what they've gotten from the telepsychs, and the telepsych and their primary care physician work closely together, so that when our participant graduates and goes into our aftercare program or another aftercare program in the community, they still have that same primary physician, and they're still working on those same needs even when they graduate. And even not just the mental health aspect of it, but the physical aspect of it. So we make sure that our participants, you know, people stop drinking and using, and all of a sudden they feel the pain, or they have bad teeth, or headaches and ear infections and things like that. So we make sure that we hook them up with the proper medical care as well that follows them throughout treatment. And even from detox, we do that. We make sure that they get to any medical appointments they need to get to.
We also now offer in our social detox groups.
Yes.
So they're required to go to groups during the day. And they're also, we take back the community to AA and A meetings if they want to go. And we found that they really like that. They're really liking the structure, whereas before it was pretty much just sitting in front of a TV
Right.
while they're detoxing and then just out the door.
Right. We make sure that we keep them busy from detox into our outpatient. So there's limited TV time, there's limited phone time, and there is groups that are provided. And social detox will facilitate the majority of those groups, and it's a lot of stages of change and alcohol or drug education, right? It's not nothing too intense because we don't want to scare them off, right? We want to bring them in. So I think I will hand it over to Will now and have him kind of explain. Will is also an alumni of Ernie Turner Center, so he's a success story of how we help provide productive members of the society.
Thank you, guys. Yeah, I'm Will. I'm an alcoholic. And I got sober July the 3rd of 2010. And what happened there was I started drinking when I was 8 years old, and then doing drugs at 9. And so I was showing up to 3rd grade while other kids were eating crayons. I was either puking or had diarrhea. So it wasn't pretty. And along with that came, like, of course, the evil stepfather. So, there was some trauma and, shame and guilt, anger, fear. And, so on top of that, now there's PTSD and alcoholism. So some of that co-occurring stuff you were talking about. And the doctor was talking about. And, trips to jail, and then treatment and outpatient treatment and meetings. And none of it sank in. And I would try to be a productive member of society until I went to jail. And then, get out of jail in that cycle that you talked about, the revolving door that I was in that revolving door. And, drugs and booze and the nightlife and stealing and trespassing and blunt force trauma, and all the head injuries and brain damage from the drugs and brain damage from the lifestyle and just that whole thing of depending on alcohol and depending on drugs, you know, for, on a daily basis, you know. I wouldn't eat, you know, and, I would just drink. And, so that finally caught up to me, 4 years ago. And I was like, wow, this, you know, this sucks. And, I need some help. So I went to, back to jail, and then the jail said, have you ever thought about treatment? And I was like, I've heard this before. In the other jails that I went to. And I said, yeah, I have thought about treatment. And I don't know what happened, but Ernie Turnerson popped into my head. And she said, and the girl, the counselor inside the jail says, I'll Google that for you, you know, and as soon as we get released, if you ever do, maybe you can go. And so I did finally get released, and I got on an ankle monitor, and I was like, you know, I didn't know what was out there, so I was scared, you know, that fear of change and fear of success and fear of fear, you know, and but I'm doing it. I was like, I'm going to do this, and I went to that treatment center, and I was there for 7.5 months on a 6-month program. But what, I'm kind of slow. But what that place made sure that I had a grasp on this addiction, and what was I doing wrong? They kept looking at my weaknesses. You know, they'd look at my strengths, but they looking at my weaknesses and going, okay, let's beef it up here. Let's not even go into the PTSD, because you're probably making a lot of that up anyway. So, so they worked on the addiction and with me, and then do I have a safe place to live? Do I have a job? No, and no. And you know, and I got a Bible and a toothbrush, lady. You know, that was it. And so I go out and I'm doing treatment, and I go to work, and starting over, and you know, and I get out there and I start getting a paycheck, and I think about getting an apartment, and good things start to happen, and then I you know, life is good, and I'm going to meetings, and I get a sponsor in Alcoholics Anonymous. And then the treatment center says, okay, call us every 6 months and we'll knock $100 off your bill. And I said, well, what about every 6 weeks? And I said, nice try. But I did that. And then I did that I did it for, you know, it seemed like a couple of years. And I'd call every 6 months and say, guys, I'm sober. And I can't believe it. And they said, would you like a job? And I said, no. And they said, good, you'll start tomorrow. And and I started out as maintenance. And then I'm working on the building, and then they said, you're gonna do groups. We're gonna teach you how to be a counselor, and you're gonna be doing groups. And this whole thing's gonna take about a year, and you're gonna be good. Don't worry about it. And you know, in 1 year, about this time next year, you're gonna be doing groups. I think it was about 6 minutes later, they handed me a piece of paper and told me to go upstairs and do a group. And I was like, wow, you know, what do you guys want to talk about? And I'm in the detox unit. And I was that person. You know, no hope. I didn't have any hope. Nowhere to live. No money. No clothes. I got a toothbrush and a Bible that I stole. And and then now that, you know, you start to see people like me go in there, and there is hope. There's hope. And you see the light comes on in these people, and I was like, yeah, that's. I was there. I was that person that, you know, didn't see a way out at all, and then all of a sudden, I'm not wanting to commit suicide every day. I'm not drinking, I'm not doing drugs, and I'm not hanging out in strip joints as much. And it's a brave new world, and I think it's because someone saw something in me that I didn't see, and they were like, yeah, you can do this. And here is a 401k plan and a paycheck every 2 weeks with full benefits and a $3 an hour raise. I said, oh, okay, well, I can probably do that. I want a glass bottom bungalow in Bora Bora, I'll let you know. But I really appreciate cooking at Tribal Council, and I really love my job. And I've never had a paycheck every 2 weeks for 2 years. And I've had that. I celebrated 2 years at the company yesterday, and I'm gonna retire someday. It might be 18 more years from now, but I'm gonna retire, and I'm gonna have a little bit of money what I don't spend for retirement. And I got benefits. I just got brand new glass 2 days ago, and they were $800, and I didn't have $800, but I got benefits. And they're talking about yanking some of my teeth out, but I got dental. So I'm in good shape today because of it's because somebody saw something in me that I didn't see, and they took the time out, to help me. And I think I'd be either like they talk about jail, institutions, and death are my three choices, and pick one, and that's where I was, and I don't do that anymore. I don't like the food in jail, and they don't serve coffee, so I'm gonna try to stay out of there, and the best I can. And there's another shift that happened where I really didn't like people for most of my life, and now I'm a social worker, so it's kind of strange anomaly also. I don't have much more to say, guys. I'm just happy to be here. This is a privilege. This is an honor. Thank you for having me.
For Ag Cook and the Tribal Council as a whole, especially within Recovery Services and Earning Care Center, we like to take a very holistic trauma-informed care approach with our people and with our population. We provide a lot of cultural things as well. Like Beth had mentioned, we also provide a lot of outside support groups, because once they graduate either program, that's what they're going to have to rely on, is that support. Right, so we want to provide them more support than just us. We have one participant who, within residential, we have a work therapy program, and we provide an opportunity for them to do work therapy within Cook Inlet Tribal Council, and one of them just recently went to nursing school and did her work therapy through nursing school. We have another person who went through our IT department and did work therapy because he wants to work for GCI. And we have another participant who just recently graduated in our aftercare program, who is now doing the cultural support group, providing outpatient and teaching other participants how to make cookbooks and things like that. And through our social detox program and our medical detox program, with the intense case management that they have from this fine case manager right here, we've been able to place at least 1 to 2 people in residential a week. And we've been able to place at least 4 to 5 in outpatient, at least 8 to 12 in an outside community support group. You know, we have a pre-treatment group as well, and we have intakes into our outpatient program every week. So we're constantly serving our population to help keep them off the streets, or at least harm reduction, you know, so that they're able to know that we're here, no matter what happens.
Thank you very much for the presentations. Are there any questions from the group? Seeing, I just have a couple quick ones. How many detox beds do you have currently?
We have
14?
Mm-hmm.
And are those are those part of those reserved for Alaska Natives, or are those 14 available for anyone?
They're available for anybody.
And what is have you had more detox beds in the past? Or has that 14 been your max?
14's been the max. I think we had less before when we just recently got.
Do you have the capacity to add more detox beds to your current operation? Not if you had the funding, obviously, for it.
I'm sure we could. I don't know that I could really answer that question with a direct answer, but I mean, anything's possible.
Sure. I mean, one of the issues we are dealing with, obviously, is increasing the number of
Yes.
detox beds, which leads to all the other services that you're providing. So one of the things that would be helpful for us to know is what is the cost for every bed we add, and also your views on, you have 14 beds. Are there a number of people waiting that you know of to get into these beds, and how many more beds would you think would be required, either in your facility or citywide, to meet that pent-up demand? You don't have to answer right now, but if you can, go back and come up with the answers to those questions, it would certainly be helpful. Do you have a question?
I have a comment.
Go ahead. I'm sorry. I didn't mean to-
I was just saying, I'm gonna leave my card for you guys too. So,
You'll be hearing from us.
yes.
Ms. Graycheck?
Thank you,
And then
Mr. Chairman.
Green.
I'm really appreciating and enjoying hearing the presentations from the nonprofits. But, most of them are just really, sad stories, and we need to do something about it. So I'm really, really pleased. Thank you so much for sharing your remarkable, wonderful success story. It's just refreshing. And good luck to you. You're welcome. Thank you, Mr. Chairman.
Mr. Trainee?
Thank you, Mr. Chairman. Your building is in my center district in Miss Gray Jackson. And we've never had one single complaint funded to us on what goes on there. So and that doesn't happen very often. You guys run a great program. What's your biggest challenge right now that you've got? Success, or because you sound successful, what's your biggest problem you're facing now?
So when it comes to detox, our biggest challenge is nursing regulations.
Yes.
So when someone comes into detox, within a few hours they have to have something that's called a CWA. In other states, you can have CMAs do it, but in this state, it has to be done by an RN. And so we can only have so many RNs during certain times of the day, so we can't do those admits that we need. So we're trying to work with the nursing board.
Yes.
It's a state issue.
That could be.
Yeah, I mean, that's huge.
Could you just send us a brief synopsis on what the problem is, and see if we know the people in Juneau, and see if we can try and help
Yes.
you resolve that problem.
Absolutely.
Try to blast them right out of Juneau.
So we
That's
can
what
change
Tom
some of the
Fink used to
regulations
say.
down there.
I just,
There's no money, but we can change the regulations.
Just to wrap up, again, I have just to echo what Ms. Gray Jackson said. Will, I appreciate you sharing your story with us. We talk about abstracts about chronic inebriates and just use that term in different programs. I think it's very helpful for policymakers to see the actual people that are at the other end of those statistics. At the end of the day, we're not investing in programs necessarily, we're investing in people. So it's really helpful to have that experience. So thank you very much.
Thank you, Mr. Chairman. Congratulations.
Thank you, sir.
Thank you.
Okay, moving on in our very busy schedule here. Mr. Stoltman from Department of Corrections is our next presenter.
He
is not here.
He's going to be back.
Okay.
He was here at the beginning,
Okay.
so we can move on.
Sure. Why don't we hear from Battalion Chief Dennis on the public inebriate initiative they have going?
Okay, so if you will indulge me for just a moment. Again, I'm Melinda Freeman, the Director of the Department of Health and Human Services, and we have been working extensively with AFD and APD on several initiatives, and Battalion Chief Dennis will explain it more thoroughly, but we wanted to make sure that our participants, in addition to the assembly members, have the newest 2014 data summary on the Safety Center statistics in order to incorporate that and be the backdrop and the context for the no-cell ordinance. We also have Mr. Todd Sherwood from our legal department who drafted the ordinance and has worked extensively with our group of uni partners and community members on the no-cell ordinance. So I will pass it over to Chief Dennis to explain both the purpose of the ordinance, the no-cell ordinance, and the mechanism and the function of how it will work within the system.
So the Anchorage Fire Department, the Department of Health and Human Services, and the Anchorage Police Department have been working cooperatively for some time now in trying to come up with a stopgap measure for the public inebriate issues we're having citywide, not just in the downtown area. And this came about in one of those 3 o'clock in the morning situations in a fire station. And I'm having a discussion with a couple of firefighters who are battling and dealing with the same issues that I was dealing with 20 years ago on Medic 1 and Medic 3 as well. Running 18, 20 calls a shift on one ambulance, running on public inebriates, who technically at that point do or do not have a viable medical issue. Some of which don't, and get moved on with ASP over to the safety center. Some which do have a medical emergency, in which case they are transported to an emergency facility, an emergency room. So let there be no confusion that ambulances transport to emergency rooms, and APD and ASP transport to a safety center. Anchorage Fire Department itself as an ambulance does not transport to ASP, because if they do, one, it's Cobra law, and if we're transporting an ambulance, they're deemed a patient. So under Title 47, of course, these people are unable to care for themselves, so then are put into a van and taken to ASP for observation. So as we're talking at 3 o'clock in the morning, we're rolling over this discussion, this process of we're built in a response capability. We're trained to react, and we're trained daily on what to do if this happens. What we don't do a lot of times is look at the situation that's happening and say, how do we stop it before it occurs? And we try that through fire prevention and inspections and things like that for structural stuff. For other issues, medical specifically, we take a response again. Okay, what do we do if the person's heart stops? Well, we're going to do this, and this. What happens if they're having a stroke? We're going to do this, and this. But we don't get into how to prevent a stroke before it occurs. That's up to the individual. We don't get into how to stop a heart attack before it occurs. Other organizations do that. And so the fire department's done a transition in looking at what can we do for the people that were sworn an oath to take care of and to serve before those things occur. One of them is Miss Linda. You see the pink fire engine driving around. It's a wonderful project, and hundreds of people have gone out and sought cancer screenings because of a pink fire engine. It's fantastic. And I know of somebody specifically who has gone out because of that fire engine, sought a screening, found cancer, and is seeking treatment to this day early on, who has a wonderful potential outcome, all because of the pink fire engine. So in this process a year and a half ago, we're working through what can we do ahead of time. Well, we know one thing we need to look at is how do we stop the endless cycle of drinking for people who are those chronic inebriates. And I'm not talking about people just downtown, I'm talking about citywide. If you live on Hillside and sorry about that, if you can look at it too. If you live on Hillside and you make 4 $500,000 a year, and you are continuously publicly inebriated and need care, you are using the same system as everyone else is who is publicly inebriated and needs care. So, without looking at any one particular socioeconomic group, things like that, something that is diverse, that can serve the entire community, we came up with a process that will provide a moment of sobriety, and that's what we're looking for. So we drafted, in conjunction with Department of Health and Human Services, Anchorage Police Department, Anchorage Fire Department, and other agencies, we've drafted a city ordinance which allows the process to stop serving alcohol from packaged liquor stores to persons who utilize ASP entrance more than 3 times in a calendar year. And I think most people would agree that if you're in a sleep-off center more than 3 times in a year, you probably have a drinking problem. You probably have a public inebriation issue. So the good part about this program is that we already have the systems in place to actually make this functionally work. People are safely transported to one site where they can be admitted and cared for. So we have a single point of entry, so that it's not disseminated amongst multiple agencies trying to gather all this information. It's through one single point of entry. The other good news is we already have the system in place. When they are tracked, when they're brought into the center, they're registered like any other person, so we need to know who's there, how long they're there, and when they're released. So that data is already there. The other good part about this is that moment of sobriety, as they enter once, they enter twice, they enter the 3rd time, it gives us an opportunity to provide them information of, you've been here 1 time, these are your options to go to for services and for assistance. Here, let us help you. The 2nd time, they're then provided with another sheet, a different colored sheet. You've been here 2 times, these are the options you have to go to. This is what we can do to help you in service you. And then the 3rd time, these are the services we can provide, this is how we can help you. If somebody is admitted incorrectly or there's a challenge to it, there is an arbitration process involved in here that allows them to be able to go and seek to be removed from the list. Now the list, there's a lot of confusion about this list and how it works. It doesn't hold anybody's information. It doesn't hold any data. What it does is, as the packaged liquor store goes to sell, they take a driver's license and they scan it. And it doesn't scan to see what they've purchased or how many times they've purchased or if they're any of that information. What it does is it reaches into a database to see how many times they've been admitted into ASP by their driver's license number or ID number. If it's got 3 entries within a 12-month period, it comes back with a red light. And it says, just red light means not to sell. If they don't have 3 admittance into that ASP system, then it's a green light, meaning they can sell. And that's the basis of the system. But to remember, this doesn't limit the person or people from using ASP services over and over again, because we want them to have a safe place to go. We want them to get care. We want them to be in that environment where they are not cold. They do still get alcohol by a friend or some other source. We want them to still be able to use these services. And now, let's think about this in this core group right here. We're all public inebriates together, okay? So, I've used ASP 3 times. Okay, Chief's a good friend of mine. Chief, he needs to go buy me some alcohol. Sure. He hasn't gone to ASP 3 times. So he's going to give me some alcohol. So am I going to have more than 3 admittance to ASP? Yes. Because I'm going to go back again tonight after he's purchased the alcohol. And now he gets admitted with me, and he gets admitted 3 times. Now he can't purchase alcohol. And I'm going to have you purchase us alcohol. And then eventually he gets 3 times. And then 3 times, and then 3 times, and then 3 times. Now, if you look at the data and how this data works, we're looking at a core group, correct me if I'm wrong, 400 to 500?
That's probably high.
That's high.
Yeah, I'd say around 2 to 250.
Okay, so 250 people of core users of ASP, and we're looking at 22,000 times in a year, correct? 26,000 times? So we're looking at this 250 mark at 26,000 entries. Well, even at that number, if we all used it 3 times, we're talking in less than a 2-month period, we've already captured the core group of public inebriates who are utilizing the system 26,000 times in less than 2 months. We now no longer have legal access to alcohol in the municipality of Anchorage. And that's the proposed process we have from the Anchorage Fire Department, Department of Health and Human Services, and Anchorage Police Department. A gap measure to get a moment of sobriety to assist them in seeking the actual assistance they need to become sober.
Mr. Train?
Thank you, Mr. Chairman. Char's got a representative here. I want to ask Sylvia if Char's looked at this.
Sure.
I know you were something else now, Sylvia. I know. But Char's easier for me to remember. Have you guys
This is an
looked at
S version
yet?
I just got about 5 minutes ago. I have not read it.
Oh, okay. I'd
This is
love
an
to
S
know what the
version I
difference
just got.
is.
Thanks.
Who
Mr.
gave it to
Sherwood?
you?
Yes.
Todd Sherwood.
Todd Sherwood? Because I want to know what the difference
Todd
is.
Sherwood. I don't know
So
what
I'm
the
going
difference
to
is.
ask him what the difference is. Thank you. Thank
So
you.
we're just getting older. We can't hear you. It's
I'm on to some,
no, you're not. We are. She's not.
what, our concern is gonna be, and I think the idea is great, because I've talked to you guys about the same thing, you know, we have a centralized place where it's being abused repeatedly by the same core group. And, the scanning system is okay, but who's gonna pay for that? I'm sure the package stores are gonna come to me and say, who's gonna pay for this? A place like Brown Jug, that they have multiple cash registers, you know, they have to have one in each register, I'm sure, so what's the cost there? And then the other thing is the mouthwash, the hand sanitizer, and the vanilla extract. They're gonna buy that regardless. So, you know, are we gonna tell Safeway and the other grocery stores that they need to put those away as well? But that's a lot of the problems. Jonah, you pick up a lot of mouthwash. I'm sorry, this is Jonah, he's a supervisor for Ira. And, you pick up a lot of mouthwash and.
Thank you, Mr. Chairman. So I didn't want to go on one, but I want to get that from you. We're going to have a work session on this before it comes to the assembly, so
Is this the ordinance?
it's the ordinance.
So that'd be good, if you can let us know, and then we'll go ahead and work with you. Of course, you know, we are not, especially Arbor, I wear two hats. I wear Alaska Hospitality Retailers, and I wear Arbor's hats. You know, Arbor's been working a lot with the homeless, chronic inebriates, and this is a good thing. And the same thing we feel with the other association, but there's a little things that we need to work on.
Thank you, Mr. Chairman. Sorry to take your time.
Ms. Gray Jackson, I believe, has a comment for Mr. Sherwood.
Thank you, Mr. Chairman. First, I really appreciate you bringing this forward, Captain Dennis, or Chief Dennis, because it really is a good thing. And of course, with anything that comes forward to this, I mean, you know, there's always things that need to be worked out, so I'm sure they will be. But my question to you, Mr. Sherwood, is we were just handed a substitute version, and I looked at the original version before this meeting, and I'd like to know what the difference is, if you can briefly tell us. Thank you, Mr. Chairman.
Well, there should be a substitute version because I'm actually still working on it on my computer, so.
I just wanted to see if, did it say S1?
It doesn't say yes.
No, it doesn't.
Ours says you'd have to have the S version.
Excuse me, well, we were just told that it was a substitute version.
We handed out some of the ordinance, you're in the safety committee, so when was that, last week?
Last week we had a public safety committee.
Yes, and we were there and we gave out that version of the ordinance at that time, so I didn't know, you said there was an S version today.
Well, it's on my computer and I'm working on it.
Okay,
It's
so
not-
this is the same ordinance that you
Okay.
received the other day then?
But I'll mention that because what the change is just, I noticed when I was working on this a little bit this morning that we needed to do a fix to the penalty provision, and that's the only change from what was introduced on the 28th until now. And it just makes it clear what the penalty is and that the bar would have the option to appeal it to the hearing officer.
Okay. Thank you, Mr. Chairman.
Mr. Train?
Thanks, Mr. Chairman. I've seen here the licensee will have to pay for the cost of the equipment of doing this.
Yes.
How are we going to make sure that is honored? Are we going to have zoning enforcement check this, or what's to make sure that it goes red and they sell it to them anyway? What's the process to make sure that this is complied with?
There's in the code, there's a definition of code enforcement officer, which includes police officer. And I mean, it's really up to the agency. There could be spot checks, or it could be that the sleep-off center gets someone and, you know, they say, yeah, that was my 4th time at such and such a place, and then we go look. I mean, there could even be a you know, ABC-style sting operation. I think that would be up to the agencies as to actually how they enforce it.
Just something you can think about as you work on this version. Thank you. Thank you, Mr. Chairman.
Any other questions for presenters?
Could I just make a couple comments from the legal aspect? Because I think the committee might be interested in knowing this, because when this first became an idea from the fire department, I did a lot of research, and my sense is these types of ordinances used to be much more common at one time, and they were basically the kind of thing, literally, where a family member, usually a wife, could go to the local police chief and say, put my husband on the list, he's drinking up our paycheck. And it went to the U.S. Supreme Court, that type of thing, from a Wisconsin law in 1971. And the U.S. Supreme Court said, that's unconstitutional. They said you can regulate alcohol as much as you want. There's almost no restrictions on regulation. There is no constitutional right to drink. But you've attached a stigma to this when you put a person on this list with no due process at all as to how they get there or how they get off. Well, fast forward to current times, then I think Fairview Community Council got kind of involved in this idea. And you're saying they were doing this in Green Bay, Wisconsin, and I talked to some people there, exchanged emails with them. Their current system basically is a, quote, voluntary system, and the police go around with a list that has photographs in it, and they say, keep that behind the counter, and this is voluntary, but by the way, if you don't do this, when your license comes up for renewal, it can be considered. So one, it's not really voluntary. 2, they still don't have an appeal system that we've built in here. And I'm not providing advice to Wisconsin, but I think there's multiple ways for that to be challenged. So in many ways, this ordinance is unique in the nation from what I can tell. There's Pinellas County in Florida has one, not like this, but in Devils Lake, North Dakota, but they don't have these due process provisions built into it like we have, and as near as I can tell, they're not really used. Fairbanks actually looked at passing something along these lines in 2009, and it didn't pass up there. So anyway, I just wanted to mention that we feel like we put a lot of thought into those aspects of it. And there was also discussion of sort of what should the trigger be, but we needed a bright line, and so literally 3 times across the threshold in the sleep-off center establishes that. We talked about things like alcohol-related police contacts. Well, that's very vague. There's no way to really establish what that is. And also built into this is the ability of the mayor or the mayor's designee to suspend the program if it looks like there's any public safety, health-related thing going on, because the one thing we didn't want to have happen was people saying, oh, I'm not going to go to the sleep-off center.
We have lots of questions. Mr. Peterson, Mr. Trainey, and then Ms. Ray Jackson, and then Mr. Constable.
Thank you, Mr. Chairman. And so my question is, if we start restricting street inebriates from being able to purchase alcohol, they go into involuntary detox on the street, and they start having health problems. And so, I mean,
I can answer that.
Yeah.
That happens now. There's times now where public inebriates that don't have access to alcohol, and they do start to go through withdrawals. Those patients will likely have a seizure or call 911 themselves from their own cell phone, which are given out downtown regularly anyway. So they call 911 themselves and say that I need to go to the hospital. We transport them to the hospital because now DTs are technically a medical emergency. They need medication, they need hydration, they need medical monitoring, in which case we transport them to the emergency room, where they're then treated and then released and hopefully given, as Dr. Levin was saying before, follow-up care in the process of for a particular medical emergency. Oftentimes when we transport public inebriates, they have an underlying medical condition occurring at the same time. So it's incumbent upon our people to, meaning the fire department's people, to constantly be looking beyond the fact that the person is either going through DTs or going is inebriated, because they lead a very unhealthy lifestyle. So due to infection and other conditions, they're transported to the emergency room.
And
Peterson.
just to follow up, so if someone that is put on this list and no longer can buy alcohol goes into DTs and passes away, is the muni liable? Can their relatives come back at us and say it's our fault because we wouldn't allow them to continue to be able to buy alcohol?
Well, I would never say never, but I think it would be an impossible case to win, because for them, not for us, because there's so many factors that get them to that point. Plus, as he says, it happens anyway. The ambulance there, the reason for the illness is not going to be the lack of alcohol. The sleep-off center is still there. All the options, all the city services are still there. And, there's limits to Title 47, even what can be done in that. So, no, I don't see that as being an issue.
Yeah, the opposite argument is that Budweiser's now somehow liable because someone drank so much that they had a seizure and passed away due to a closed airway.
We have another presenter, so I'm going to ask everybody to be as quick as possible with the questions and answers. Mr. Trainee?
Thank you, Mr. Chairman. I got one quick question, then Ms. Mosier has a couple of questions, good ones. As you're putting this together, I heard you say something about the mayor being able to suspend it. It's a policy decision that's passed by the assembly. Please put in there, it could be suspended by the mayor at concurrence of the assembly, because I guarantee you when I do an amendment to your ordinance, it will be put in there. Because if we're going to do this, the assembly's going to adopt it. We're not going to have simply one person decide arbitrarily to shut it off. It's a policy decision that's set by the assembly. So believe me, I will craft it in documents, sir. Thank you, Mr. Chairman.
Thank you, Mr. Trainee. Ms. Gray Jackson.
Thank you, Mr. Chairman. Mr. Sherwood, did I hear you say that Anchorage could very well be the first community with an ordinance such as this?
With these aspects that look out for due process and providing information and those kinds of things. From what I can tell, yes.
Okay. Well, I'll go a little bit further and say, well, I'm really pleased to hear that. And the biggest reason why is I think, number one, I think this is going to work. Okay. And part of our mission statement, this committee's mission statement, says that, solutions that will make Anchorage the model city for dealing with the problems associated with the chronically homeless. And so, we're going to reach our goal, at least to some extent, with this ordinance. So thank you. Thank you, Mr. Chairman.
Sure. Before Chris explodes out there, quick question.
I just want to address Mr. Peterson's question. This is exactly what I was hoping to speak about briefly. Christopher Constant here from Fairview Business Association and Community Council. The reason that when we got started way back, as we started to address what can we do, we decided that we wanted to move forward with the municipal effort to restrict the sale to these individuals, but we also realized at the same time that there's a health crisis that could be created. And what we did is we decided we couldn't just be the stick, we needed to be the carrot. And so we went to Juneau and advocated for $5 million to create a whole new service delivery system with really intensively ramped up services for this population that will include intensive outreach, intensive case management, and the building of a whole team to manage these people. Our theory at the beginning was, before we go with the stick, we need to have a pathway for these people to move into a path that's going to make them more healthy and give them options. So the rationale behind the $4 million was, we're not going to be the ones who cause these people to die on the street, but instead we're going to be the ones that open the door for them when the other door closes. And so just from a matter of philosophy, that's where this originated, from the neighborhood.
Great, thank you.
And those services come to bear on the 1st of July. So the timing is really good.
Thank you, Mr. Constant. Amanda, you had some
I
questions?
can take my questions offline.
Okay.
Mr. Sherwood.
One additional answer to your question too about liability that is worth remembering. The court system does this all the time. Both pre-sentence and post-sentence says flat no alcohol. And the state has the red stripe on ID cards already. So in that sense, it's out there. I don't know how effective it is because I don't know a lot about it, but it's already being done by the state in a different way.
Right.
Thank you, Chief.
Mr. Chairman, I just want to say just one thing, that we will look diligently to find some way to pay for this activity for the users, and we'll see how that works.
Appreciate that. Thank you all for being here and making the presentation, and just thank you to the fire department for being, proactive in a way that is meant to benefit the entire municipality as well as yourselves. But appreciate that approach. Thank you very much.
Thank you.
Our last presenter today is Mr. Stoltman from the Department of Corrections. Mr. Stoltman, if you could. Thank you for your patience and waiting to the end of the line.
Well, I kind of back. Place I can see.
Yeah, wherever works for you.
Well, I don't speak so loud, so I'll. Yep. you bet. So just briefly about, just a sentence about me, and that's all it takes. I've worked about 25 years off and on with Department of Corrections and mental health. I'm a mental health clinician, and now I'm semi-retired and I do special projects, and we're trying to see if we can open up some new units here, even at Anchorage Jail Complex, for treating mentally ill folks. And what I want to start with then first is definitions. So when I use terms like Anchorage Jail and Anchorage Correctional Complex, cooking the pretrial, people know what that means. Maybe you do, but I just want to be sure. What we have down the street, a few blocks here, is Anchorage Correctional Complex, broken into two buildings. One is the old building, that's what we call cooking the pretrial, which is where I work out of mostly. The other is called Anchorage Jail Complex. And that's the term we use for it. And combined, they're called Anchorage Correctional Complex East. I know this is probably confusing the hell out of you, but we have CIPT, cooking the pretrial, in Anchorage Jail. The booking facility is Anchorage Jail. That houses around 450 prisoners. Cooking the pretrial also houses around 450 prisoners. So it's a pretty large facility. A few more things about definitions. I'll talk about mental illness and what mental illness means to us, because we're pretty restrictive. Some of you may be aware that there is a manual called the Diagnostic Statistical Manual. It's the DSM-4 and 5. It's 2 inches thick. It's got every diagnosis you could ever think of. We don't use 99% of that. The folks that we see are simply this. We see schizophrenics. We see schizoaffective people, which is a hybrid between schizophrenics and people with mood disorders. We see people with bipolar disorder, with brain injuries, traumatic brain injuries, and developmentally disabled people. That's the core group of who we work with in mental health. Probably 85% of the prisoners on our units are schizophrenics. So I want to just kind of walk you through a little bit. I don't know if this is information helpful for you, and you be the judge. Just a typical scenario, what happens when a mentally ill person enters jail. So let me give you just a scenario or a story about a guy. I actually interviewed him this morning, and I've known him for quite a while. I'm going to call him Inmate Bob. So Inmate Bob, he's 46. All the facts I'm telling you are accurate. He was born in Anchorage, but he was raised in Fairbanks. His mother was a drug addict, and his mom and dad split up when the guy was 5 years old. He developed schizophrenia at the age of 13, which is a little younger than the norm. He went to API for the first of 9 times when he was 14. He was kicked out of school when he was 15 because he was dealing drugs up in North Pole at the schools in North Pole. dealing drugs at the time. He was smoking mostly marijuana at the time, and he certainly graduated. And I'll get into that and other things later. While in Fairbanks, he had 14 admissions to the 4th floor psychiatric unit at Fairbanks Memorial Hospital. He's made 1 suicide attempt in his lifetime. He was put on Social Security disability when he was 18 for his illness, mental illness. Basically unable to work throughout his entire life. And like I say, he's 46 years old right now. He's developed a very serious drug habit with crack cocaine, alcohol, marijuana, and spice, which is synthetic cannabis. His diagnosis today is schizophrenia undifferentiated type. He hears voices every day, constantly, otherwise hallucinates. He's very disorganized in the way he thinks. He's very impaired in how he can organize information. His memory is very, very poor, and so it's really hard to teach this man things, to learn things. So the best we can do is provide him a safe, structured treatment environment, which we do. I've known this guy for 3 years. He was arrested in June of 2012 for rape, for sexually assaulting a female who was unconscious right down near City Park here, Midland Day. He got a 10-year sentence for sexual assault in the second, 5 years suspended, and he's got 10 years probation, which he will begin to serve when he gets released to this community in October of this year. He's out, and he's a dangerous guy. He's dangerous because he's very impaired, he's very ill, and he's not a career criminal. This is only his 3rd offense, which is good. So that's who we work with. We see these kind of guys every day. And going down my list here, my outline. So beyond this kind of case where we have somebody enter in on a new charge, the most frequent offenders we see are guys coming through on violations of conditions of probation. Usually it's using substances. They're going to get picked up, or they're not making it to their PO meetings, or they're not making it to court. So they get called back into jail. And we see anyone, a range of crimes from minor trespassing to murder to whole gamut. Arraignments, the only reason arraignments are delayed for some of our people, doesn't happen very often, but when someone is on full suicide precautions, they are intent on killing themselves and are highly agitated. We will not bring them to the judge for the arraignment. We need to get them through that a little bit and then we'll move on with them. Once they're through arraignment and we're hopeful or confident they've been sobered up with some because of their use of spice, alcohol, heroin, and methamphetamine, which the order of frequency as far as what we see at Anchorage Jail in terms of people impaired is alcohol is number 1. Let me make sure I ask. Alcohol is number 1. Spice is number 2. Heroin is 3, and then methamphetamine. That's the order of what we see coming off the streets. So once they've been somewhat detoxed, and they are obviously mentally ill, and they need to be placed in a mental health unit, we will put them on the list to either move to our acute mental health unit, our subacute mental health unit, depending on gender. They're going to go to CIPT, or they're going to go to Highland Mountain. Highland Mountains are female facilities. Frequently, in the process of being arraigned and then the other preliminary court hearings, they will have a competency evaluation ordered from API, and that it happens about 40 to 50% of the time. Now, what do we do for treatment? And I guess that's a subjective or questionable term. What's treatment? In Mike-Mod, it's our most acute unit, probably the most acutely ill people in our state. That is mainly medication treatment. And folks there are usually in one cell by themselves. We have actually 20 fellows there this morning. And of those 12, we have, of those 20, 12 of them are locked in their cells singly. They're on two-man full restraint status. What that means is these guys are very dangerous. When they're coming out of their cell, they're in leg irons, belly chains, and handcuffs. And there are 2 officers at their side at all times. So they're not participating in any group. They're not capable of doing it. They're quite sick and quite dangerous. The other program which I had a hand in helping to start up was our Lima mod. That is actually our psychotherapy mod. That's where real, in my view, real treatment occurs. We're actually sitting down in a group and talking about issues that are really important. And we have a full gamut of treatment topics we cover with some excellent therapists. This has been a really neat addition to our program. We started that in 2011. So beyond Mike and Lima, which are right here in town, we then move people once they get through the court process and get convicted, sentenced. We're going to move on to Spring Creek, which is what you see, SCCC, which is Spring Creek Correctional Center, to Echo Mod. Echo Mod houses between 50 and 60 men. They have to be sentenced. Many are lifers. Some are relatively short sentence folks, and this is a maximum security institution. Palmer Correctional is also an option at House 1. They have 40 beds there. That's also for sentenced men only. And this is for people with medium to short sentences. Highland Mountain has an acute mental health unit, which is always overcrowded, and that's a 15-bed unit. And then they have 2 subacute units called Hopeland, 1 and 2 or something. And that's good services. So as far as case management, what do we do to help once their sentence winds down and they're getting close to release? We try to bring them back to usually to Anchorage if they've been out at Palmer, or been in Seward, or maybe down in Juneau. We try to bring them back to Anchorage where we can provide more intensive case management and prepare them for release. Unfortunately, we have a release team that helps with programs like APIC and IDP Plus. APIC is what that acronym stands for, is Assess, Plan, Identify, Coordinate. It is a program funded by the Mental Health Trust. We think it's fabulous. In 2014, they served 293 seriously mentally ill men and women with housing, bus passes, IDs, and a linkage to community mental health services. It's really a good program. The institutional IDP Plus is the institutional discharge project, and that is essentially that's a mental health PO, is the way probation officer. It just happens to be somebody who's a mental health clinician, and they will help supervise felons who are released, usually just here in Anchorage. Now, moving on here to rehabilitation. If we need to stop at 1, I'll make sure I shut up.
We do need to stop at 1.
Okay. And, rehabilitate, never mind, let's get that.
Actually, Mr. Trainee has a question for you. Maybe
Yes, sir.
You talked about spice, its use. Has that gone down since we passed the ordinance a while back?
No.
Really?
Not gone
Not
down?
at all.
Okay, thank you.
It's all over in many institutions, it's all over.
We spent a lot of time on that one, so it's disheartening to know it didn't work at all.
The feds need to pass a law.
There's a way.
Yeah, there's no federal law against it, so they ship it up, UPS or whatever.
Sorry to bother you, Chairman, thank you.
No.
Oh, man.
Please continue, Mr.
Sure. Let me just move on to the second page here, DOC by the numbers, and just give you a glimpse of this. And some of this came from our commissioner at a conference we attended here last month. In 2014, we had 37,160 bookings throughout the entire state. Now, what bookings means is not only people arrested, but the transfers through our booking facilities, so transfers. At any given day, we'll have around 10 to 20 guys transferred from the east building to the west building. That's a booking transfer. So the numbers get kind of inflated. We got a 1,500 bed facility in Wasilla, and it's like busloads get transferred in, busloads get transferred. It's crazy. So there's a lot of that traffic. So at Anchorage Jail last year, we had 21,223 bookings, out of which 16,500 were actual new remands. So we get about 45 guys, women, men arrested every day. It is by a long shot our busiest booking facility in the state. And out of that 45 people arrested, about 8 of them required mental health services. And we're fortunate that we've got 3 mental health clinicians at Anchorage Jail that do nothing but that. They will intervene and see these people, line them up to see psychiatrists if that's needed, transfer them to our treatment facilities, or recommend to the officer just sit on suicide watch. So we currently have 6,300 men and women in custody throughout the state. At Anchorage Jail, our daily census is usually around 900. At Highland Mountain, it's about 450. We have 12 facilities in Alaska. And this is an unbelievable number. 65% of all offenders are beneficiaries of the Mental Health Trust. It's hard for me to get my head around that. This includes mentally ill, developmentally disabled, substance abusing, the physically disabled. It's a huge umbrella. Now, we don't see that kind of people, those numbers where I work. I mentioned something about the frequency of substances, or acute, subacute units at Anchorage Jail, plus overpopulation. We serve about 20%. So out of 900 prisoners here locally, we serve about 20% of them.
Ms. Gray Jackson has a question.
Thank you, Mr. Chairman. Can you clarify for me what it means to be a beneficiary of the Mental Health Trust? Because I don't have a clue.
Boy, that's, like I said, that's not an area that I actually, not a term I use much.
I think Mr. Jesse
I
can
think we
answer
have
that.
somebody here that.
Well, great.
It would be people with a mental illness, a chronic substance abuse problem, a developmental disability, dementia, Alzheimer's or related dementias, or traumatic brain injury.
Thank you for your comment, but I'm still not clear on who and how you become a beneficiary of the Mental Health Trust. I mean, you just named...
It's just a definition of the group of people that the trust is supposed to work for.
Okay, that's a better explanation. Thank you. Thank you, Mr. Chairman.
Let's see, at Highland Mountain, that's our women's facility, we have around 450 women, and we're serving around 175 of them, so it's 39%. So essentially, we're serving double the population, double the percentage from women to men, which I'm not exactly sure why that is, but I have some guesses. Our recidivism rate throughout our state is 63%, which is one of the highest in the United States.
Wow.
It is bad. Misdemeanors have a significantly higher rate of recidivism than felons. Of the felons, those convicted of violent and property crimes are most likely to be reconvicted of a similar crime. Since 2002, the female growth rate is nearly double that of the men. In 2014, the percentage of female offenders in custody is 11.6%. 95% of all inmates get out, get released. So, you know what, and just a side note on this. When we set up this rehabilitation unit at Procurement, one of the things that I realized is that these guys I'm working with, 95% of them are going to get out. They're going to be on the street. They're not going to be my neighbor, but they may be fairly close. Wouldn't it make sense if I tried to do something to make them safer so that I don't have to worry about somebody hurt in my neighborhood? So our philosophy has been, it is a help for the entire community if we can do anything, even if we help one of them and do some changing. We have improved the safety for everybody else.
We have to cut it off at one.
Yeah.
This quick question for you. I know it's hard to separate people because most of the folks have co-occurring disorders that you
Yes.
deal with anyway. But with respect to substance abuse treatment or issues, if somebody gets incarcerated who is, a chronic inebriate, it's obviously needing to detox, is going to detox if he's in prison or in jail. Are there things that you provide to those folks?
For detoxing?
Yes, sir.
Yes. Mainly it's not my medical, but they're gonna be held in our booking facility, and they're gonna be monitored, and vital signs taken, and then medication will be dispensed, so until they get through the rough spots. And then, and that's not a whole lot more.
Do you have any statistics on how frequently corrections has to engage in medical detox?
I don't have that.
Any other questions? Well, thank you. I appreciate it coming. Sorry I had to cut you off. It was very helpful information. Thank you. And since we're at 1 o'clock and our meeting's only noticed to 1, we have to end it here. Unless there's any emergency questions from anybody.
Just want a quick comment, and that is that, currently the municipality is working on 2 initiatives with our partner agencies. One is the snow cell ordinance, which involves Fairview Community Council, the Business Association, AFD, APD. In addition to that, as we're all aware, Mayor Sullivan has put forward the counter conditioning pilot project, which would involve Shadle, so we'll be involving community and assembly input on that. We'd like a specific work session on that opportunity as well, so we'll be in contact about that through the chair.
Great. Thank you, Mr. Lund. Appreciate that. And seeing nothing further, we are adjourned.